Hello, and welcome to today's session on diabetes and cardiovascular health, offered in partnership by DiabetesSisters and Pri-Med. We welcome experts Dr. Rachel Bond and Dr. Frank Lavernia, and DiabetesSisters CEO Anna Norton. Today, we will cover important information about treatment options for people with diabetes. Before we get started, let me remind everyone that this event is supported by an independent educational grant from Novo Nordisk. Thank you for joining us today, Dr. Bond, Dr. Lavernia, and Anna.
Good afternoon, and thank you for tuning into our special Facebook Live, Conversations about Diabetes and Cardiovascular Health. My name is Anna Norton, and I serve as CEO of DiabetesSisters. I'm also a person that lives with diabetes. Today, we're joined by two experts, Drs. Rachel Bond and Frank Lavernia. Dr. Bond is the System Director of Women's Heart Health at Dignity Health in Arizona, and the co-chair of the Women in Cardiology Committee. Dr. Lavernia is the founder and director of the North Broward Diabetes Center in Pompano Beach, Florida. Together, we will share facts and information for people with diabetes and their cardiovascular risk. We will also discuss risk factors for our community during the COVID-19 pandemic. We gratefully acknowledge Novo Nordisk for their support of this program. Let's first start with the basics. Dr. Lavernia, can you share some insights on diabetes today?
Well, hi, everybody. It's nice to meet you, Rachel, finally. And Anna, thanks for the introduction. So I went back to the CDC statistics, recent ones, and I am not a big stats guy, but I think the audience needs to kind of hear these numbers because they're quite impressive. For instance, we have about 34.2 million people in the USA that have diabetes, which is basically 10.5% of the US population. But here's the scary thought. 7.3 million, that is 21.4% of these people with diabetes are undiagnosed. So there's a lot of people walking around in the US not knowing that they have diabetes, and a lot of it has to do because they're asymptomatic. Now, when you break up this group, you're gonna, in percentiles, we talk about type 2s and type 1s and LADAs and people that have gestational diabetes, but we're gonna spend most of our times talking about type 2 people with type 2 diabetes. And that's about 90 to 95% of the population. We used to call it adult onset, but now we're starting to see a lot of young children and juveniles having, because of their obesity that they've developed, becoming type 2s. And that's a very scary thought. The rest of the group, about 5%, have type 1 diabetes, and that's what we used to call juvenile onset. But you can be in your 20s and 30s and come down with type 1 diabetes. There's other types, as I mentioned, gestationals. I think we're going to spend a few minutes talking about that. And we have MODY and people with cystic fibrosis and people that have had surgical resection of their pancreas for cancers. They can develop diabetes also. The second point that is just outstanding, and we need to mention, it's one of the most expensive medical disorders that we have in this country. And the numbers are mind-boggling. In 2012, we were spending for direct and indirect costs about $245 billion with the B. And there's been a 26% increase over the last 5 years, and now we're up to $327 billion in that period of time. So $1 out of every 7 healthcare dollars is spent on treating diabetes and its complications. Now, the last thing I want to mention, and I'll get off the demographics and the numbers, is that diabetes is the #1 cause of blindness, non-traumatic amputations, and end-stage kidney disease. And CHF, which we might get to talk with Rachel about, is really sneaking into this also. Anna?
Well, Dr. Lavernia, those numbers, they're staggering. And they continue to rise. We hear that all the time. We hear it on the news. We hear it everywhere. What are some of the the conversations that you have when you deliver a diabetes diagnosis. Are there any myths or fallacies that you're hearing from the people that you're treating when you're discussing diabetes? And how do we help to mitigate some of those fallacies and myths?
Well, it turns out that diabetes is an educational disease. I think the first thing we have to convince our patients is to understand how important it is to go back to school and learn about this disorder. So we tried to get them involved with a certified diabetic educator ASAP, so they really understand what we're trying to do with them. But some of the things that fallacies I've heard over time is, for instance, a patient may say to a group, if we're in a group environment, well, my diabetes is not as bad because I don't have to take insulin. So people equate to taking insulin as being the bad type. And it turns out that we lose many years of time, and microvascular small vessel complications pop in because we don't control them very well, because the patient feels that I'm not that sick, I'm not on insulin. And we have to convince them that no matter if you're a type 2, and usually we start them on lifestyle plus metformin and then progress to other medications. And finally, at the end, they may need insulin. So that's one of the points that we really stress to them. Another fallacy is I keep hearing that patients have borderline diabetes versus what we now really have coined as pre-diabetes. So I remember being a young kid, and maybe freshman or sophomore in high school, and Betty across the room was said to be a little pregnant. Well, no, Betty was not a little pregnant, she was pregnant. And we don't have borderline diabetes. We either have pre-diabetes or we have diabetes. And that's done diagnostically with lab testing, which can be done very easily, and we could get into that later. And finally, the other thing that I'm still hearing is people approaching me and telling me, hey, I read somewhere, I saw somewhere that there's a cure for diabetes. And I put a halt to that immediately, because I say, oh my goodness, let me know when they're going to give the Nobel Prize out, because I want to be in Stockholm when they give out the prize. Like, no, we don't have a cure, but we can offer you control so you can avoid all of these complications. But, it's a tough go, because they have this disorder 24/7 and they have to deal with it. Anna?
Thanks, Dr. Lavernia. I really love a phrase that you used. You said that diabetes is an educational disease. And when I was diagnosed 27 years ago, I wish someone had said that to me. I have learned since that it is an educational disease. It's progressive. Learn more and more about diabetes, some of the risk factors of it, but also how we manage diabetes. And that changes continuously based on what's going on in our lives. If we're developing other complications, if things change, if, the stresses of our lives or things like that. And so I think that it's very, very important from onset to really learn that diabetes is an educational disease. So we know these things now with time and with great healthcare teams. We know that diabetes puts us at risk for developing other complications. You mentioned kidney disease. We talked about retinopathy and other eye challenges, and of course, cardiovascular disease. Dr. Bond, I would love if you shared with us, what is the connection between diabetes and cardiovascular disease?
Absolutely. Well, first, I would like to say thank you, Anna, as well as Dr. Lavernia. It's a pleasure to be here on this really insightful discussion with you. I think before we delve into the connection, it's important for us to understand what cardiovascular disease is, because it's not as simple with respect to just focusing in on the heart. Now, when we think about cardiovascular disease, we know that we have arteries all throughout our body. And those arteries, when plaque, which is cholesterol that can eventually attack the lining of our arteries, that plaque can build up and it can cause issues. The plaque can build up in the arteries in our neck or in the arteries in our brain. And that puts us at a higher risk for a stroke. The plaque can also build up in the arteries of our heart, where we start to feel discomfort in our chest, or perhaps could place us at a higher risk of a heart attack. But we could also have this plaque that builds up in the arteries of our arms or our legs, where we may present with difficulty, weakness in our upper extremities, or difficulty walking, or pain or tingling in our lower extremities. So that collectively is called cardiovascular disease. And we know that when you have diabetes, particularly diabetes that's not very well controlled, the sugar in our body is attacking those arteries. So it's making the arteries more prone to have that plaque or that cholesterol start to build up. It's also making the arteries become more inflamed. And we know now through a lot of research that heart disease is an inflammatory process. So the most important thing is ensuring that we screen, one, for diabetes, as we in the cardiovascular world really do think that there is an equivalency when you have diabetes to cardiovascular disease, just because you are at a much higher risk of having a cardiac condition of some sort. One thing I do want to stress is that I'm a cardiologist, a preventive cardiologist that focuses on women's cardiovascular health. So I like to look at disparities from a gender perspective. And we know that women are actually 3 to 7-fold at a higher risk of having a cardiac event if they're diabetic compared to a male who's at about a 2 to 3-fold higher risk. So there are these disparities that we're seeing. We also know that diabetes, as Dr. Lavernia mentioned, there's a term called gestational diabetes. And gestational diabetes usually occurs during pregnancy. And we know that pregnancy nowadays is really thought to be the window to future health. And what pregnancy can tell us is what our future will look like. And it's not our far future, it's actually our rather near future. So in the next 8 to 10 years, if you have gestational diabetes, not only does that put you at a higher risk for full-blown diabetes, but also at a higher risk for cardiovascular disease. So focusing in on lifestyle changes and other risk factors are a way for us to decrease those risks.
That's great. Thank you so much for mentioning gestational diabetes among all of the other things that you discussed right now. I think working with women that live with diabetes, sometimes we hear or we get approached by women that are experiencing gestational diabetes. And then, once they deliver and they feel good again, and they feel their blood sugars are in range, they kind of forget about diabetes until what you're saying, 3 or 5, 7 years later, they're diagnosed with type 2 diabetes. And then they're like, oh no, here we go again. So I think that that's very interesting when we talk about preventative care and that window that you discussed, that pregnancy is the window to your future health and your near future health. So thank you so much.
Yeah, I would like to add to what Dr. Bond just said about the gestational side of it. So I would tell the women that are listening today that around the 24th week of their pregnancy, they should be tested by their GYN for diabetes to be sure they get diagnosed. And I would stress to them that if they do have gestational on their next pregnancy, they will have gestational again. And since I'm kind of the stats guy here today, about 50% of these women will become type 2s with time. And that can be prevented if they watch what they're doing with lifestyle.
That's great. That's a really, really good point. What about other ways that we can reduce our risk? Not in the gestational case, but living with diabetes and our risk of cardiovascular disease, in the near future or in the far future, as we know that diabetes is a progressive disease. What are some of the ways that we can reduce our risk? Can you discuss that?
Absolutely. So we know that really tight control of your sugar, your glucose, is that one way from a diabetic perspective. And we know that what that helps us with when we have tight glucose control, It more so helps us with the microvasculature. So what that entails is the arteries in your eyes, the arteries that supply the blood to the circulation in your feet or your kidneys, for example. And it does a really, really good job at that. But it doesn't do as well a job on are the macrovascular, so the larger arteries, which are the ones I discussed, which are the arteries in your heart or the arteries in the brain or the arteries in the legs. And what we want to stress is that what really does help those larger arteries are making sure your cholesterol is very well controlled. So if you do have a history of diabetes, we tend to be extremely aggressive in how low we like to get particularly your bad cholesterol. Your bad cholesterol is what we call your LDL. And that cholesterol we really want to be, typically depending on what your risk is, but we really want to make sure that it's in that well below the threshold of what would put you at a higher risk. So unequivocally, for the most part, we put, if there's not a allergy of some sort, we tend to place patients that are diabetic on cholesterol lowering medications, usually the first class being a medication in the class called a statin, for example. We also talk about other risks, and we decide based on your other risks if we should also add an aspirin, which, more recently we're having some conflicting data. Is aspirin beneficial? And should we really, I think at this point in time, the consensus is we really should ensure that we started on those that are deemed high risk. And us as clinicians have the ability to really calculate what your risk is. That's not something we would ever expect you as a patient to understand, but that's why it's so important for you to engage with your doctor and ask these particular questions. Should I be on a statin if I'm not on a statin and I'm a diabetic? Should I be on an aspirin if I'm not on an aspirin and I'm a diabetic? Another area that I think is so important is blood pressure. And we know that blood pressure is a very common risk factor for cardiovascular disease as well as for kidney disease. And we know that it's something that we can typically easily manage either through lifestyle or, if lifestyle is not enough, medication. When we talk about lifestyle, because we brought up lifestyle quite often during this conversation, we want to really make sure that you're exercising. And what I typically suggest to my patients is exercising for at least 30 minutes, 5 days a week. That could be moderate intensity exercise. And for all intents and purposes, that could just be briskly walking. We right now in the state that we're in with a lot of restrictions of going out, we have to become creative in terms of how we can stay moving and active. But nonetheless, we want to ensure that we are staying active. Another important thing is our diet. So really honing in on a plant-based diet that's low in saturated fats, high in whole grains and fruits. And you really want to ensure and really think about the fruits because they could have some hidden sugar as well. So you may want to limit that, but you really want to make your plate as colorful as possible, particularly more green as possible, because that's where we really help our arteries stay as relaxed as possible to help with the blood pressure. And also it really does help reduce that inflammation that we may see that can cause cardiovascular disease. Another more exciting thing for me as a cardiologist that we're seeing is that a lot of our newer agents out there for diabetes treatment are doing an amazing job when it comes to the cardiovascular system. So that macrovascular system, the larger arteries of the heart. And two classes in particular, one being the SGLT2 and the other one being the GP1RA. Those two classes, they work a little differently, but again, the end result is that we're seeing really exciting data out there that it's helping from a cardiovascular perspective. And just honing in on the SGLT2s, we know that those agents in particularly work by releasing both sugar and salt from the kidneys. And that's really what they target, the kidneys. In doing that, they're helping us as cardiologists, particularly for our patients that may have an underlying history of heart failure. Heart failure meaning that their muscles may not be working well. In particular, it helps us to remove a lot of that excess water. So we're noticing that this is helping people stay out of the hospital, which is such an important part, particularly in the society we're living in right now. So it helps people stay out of the hospital, and it's allowing people to live healthier, longer lives. We also know with the GLP-1s that what they're helping do is really enhance the insulin secretion. And by doing that, it's working really well on making sure that your your glucose levels are at the goal it should be, or even well below that. And again, we're also noticing that that's really taking or making a wonderful impact on the arteries of the heart. So I'm really excited, and Dr. Lavernia, I would love your thoughts on those two agents in particular as well, because I, for one, am extremely excited to see that a class of medications that were specifically dedicated to diabetes is now helping in the treatment of cardiovascular disease, even to the point that the FDA actually approved one of those medications last week, specifically for our patients that have heart failure. So it's really exciting for me as a cardiologist that we have another medication out there that can help us. And I'd love to hear your thoughts on that.
Well, you made a whole bunch of great points. Diabetes is really a triad of things. We have to control the LDL, the lousy cholesterol. And for that, you're going to need a statin. And normally it's a lifetime of statin. Once you get to goal, the reason you got to goal, I hope, is because you're eating better and you're taking your medication. Unfortunately, a lot of people stop their medications, their statins, because they talk to friends and they're told that it's going to hurt their liver or they're going to hurt their muscles. And usually that is not the case. And as I tell patients, if you stop the medication and you have angina or you have a heart attack, you will be back on a statin. So I stress that, especially after age 40. As far as blood pressure, the same issue. We stress to them the importance of the numbers they need to hit. And just like they have glucometers, and in the future they're going to have continuous glucose monitoring, they should have a monitor at home to take their blood pressures to be sure they're keeping these numbers under control. Aspirin, you mentioned, and that's a very important because that changed. A lot of people were on aspirin, and there were 3 major studies that were published in the last 2 years saying, look, aspirin's not for everybody. If you've had some kind of cardiovascular event, yes, you should be on aspirin, but if you're not, you're at risk of bleeding, specifically GI bleeding. So we've kind of moved a little bit away from aspirin unless they've had an event. So it's more of a secondary prevention. Now, as to these newer drugs, you were alluding to the cardiovascular outcome trials that was forced upon the industry to have to be tested. All these different groups, newer groups that had to jump through the hoops, and they've all been approved, but some were better than others. And you mentioned the glucagon-like peptide-1 receptor agonists, the GLP-1 receptor agonists, which are non-insulin injectables until recently. Now we have the first oral one that came out and is available now, so you don't have to inject it, but you have to once a week, but you have to take it orally every day. You also mentioned for specifically kidney disease and congestive heart failure, there's new drugs that we're pleading with the cardiology sector to help us out because there's not enough of us that take care of diabetes to take care of them. And as you nicely reminded the audience, that even one of them was just approved by the FDA to treat congestive heart failure, and they don't even have diabetes. So these are very potent drugs, very effective. These are oral agents that you take once a day. So it's very exciting times knowing that we have drugs now, not only to take care of diabetes, but also help with hypertension, no weight gain, lower risk of hypoglycemia. We've got a whole host of medications, but as it was once mentioned, they're only as good as when you take them. And this is a huge problem where patients are stopping their meds on their own. And we can tell when the drugs are stopping because a lot of the parameters we measure start going haywire. Anna?
That's really insightful, and thank you so much for sharing all of that. And I want to remind our audience that we're speaking primarily here about type 2 diabetes and the different treatments and the options for type 2 diabetes. But I do have a question about those that live with type 1 diabetes. is there any studies or any results that you have seen, as physicians, where people with type 1 diabetes are benefiting from drugs like these in preventing their risk for kidney disease and heart disease and so on and so forth?
So on these last two groups that we just talked about, on the GLP-1 receptor agonists and the SGLT2, they're still in the process. There's some studies still going on. Some of us are using these drugs off-label. Yeah, but this is something that really needs to be discussed with your personal physician, and a decision has to be made. Many times insurances won't cover once they see a type 1 diagnosis somewhere on the sheet. But I think with time, we're going to get much more information on the availability of these drugs. So right now, the main drug for type 1s are insulin, and there's all types of newer insulins that are more effective in the sense of less hypoglycemia and less weight gain. So again, it's very exciting times.
And I think what's important to stress,
I agree.
I think what's important to stress is that what both groups can benefit from is really that aggressive lifestyle modification, right? So our hope is that particularly for the type 2s, we don't have to get to the point where we have to start these medications, right? We want to really ensure that, your sugar levels are under control, your blood pressure is under control, your cholesterol is under control. And the vast majority of that is through exercising, eating healthy, making sure that you're not smoking, that you're not drinking alcohol in excess, that you're having a good mindful, mental sort of wellness. So all of that, I think, is encouraging, and really both type 1 and type 2 patients benefit from that.
Yeah, that's great. Thank you so much. I'd like to switch us a little bit and talk a little bit about us, the people that live with this disease every single day. What are some of the things that we can do to help ourselves and to help you as part of our healthcare team provide us the care that we deserve, the care that we need? So can you talk a little bit about that? What are your expectations?
So I could start off. I think that whenever I'm seeing a patient, I encourage my patients to come to the visits with questions. That way we have a more intimate conversation. I know what their concerns are. I also challenge them to really recap our visit. So I leave that visit just as they leave the visit with a clear understanding that they completely understood everything and the plan and mission that we set forth. One thing that I do want to stress is that as clinicians right now, our focus is really more patient-centered, and it should be patient-centered, right? We don't want to particularly just focus in on one aspect of a disease process, meaning myself as a cardiologist, if I just focused in on your cardiovascular care, I wouldn't be doing a good service for yourself. So if you have diabetes, if you have high blood pressure, that's important for me, because those things, if they're not under control, they do affect your cardiac system, as we talked about. So I think right now we're kind of evolving more into a world of clinicians where we want to engage each other. We want to collaborate with each other, and we want to put the patient at the center. So that way we're ensuring that we're providing the best possible care. So that's the practice that I do.
Yeah, so as Dr. Bond has mentioned, this is patient-centered, and we stress that to the patient. You're running the show. You're in the middle of all of the consultants around you. And it's basically up to you to please write your questions when you come in. Come prepared, because that tells me that you've really bought in to your disorder, and you're coming in with your medication, a list of medication, or better yet, in a bag, bring all your medications. I can't tell you how many people will come in and they're on 2 different statins, and they didn't know that, because one might be a generic and one might be a brand, and they did not know that they're taking 2 different ones, and they could get into trouble. Other things that I welcome and I insist, especially the ones that are on insulin, is to bring their logbook in, or better yet, their meter, so we can download it. I think the future in diabetes care is that we're going to we'll still use A1C, the 90-day average blood sugar, mean blood sugar that we're using right now. And we're going to shift over more to CGMs, continuous glucose monitoring, where patients are going to start to realize that even though they were having very good A1Cs, their time in range, which normally means a blood sugar of between 70 to 180 milligrams per deciliter, they were all over the place. And once you hook them up to a CGM, which means that they don't have to test, they're going to get an automatic reading every 5 minutes if they care to look at it. And then we can download that in the office and show them, look, here's what happens when you take your insulin at the wrong time after a meal, or if you skip a dose, or if you skip a meal and you took insulin. And that's when they have an aha moment about the importance of what exercise does to their blood sugars. When they skip a medication or they stop it, they start seeing right then and there that they're having problems. So I think we're going to be slowly moving away from A1Cs, and I hope that the government and the insurance companies will buy into CGMs.
Yeah, that's a really, really great point, because, for every % of increase in time in range, that gives us, people with diabetes, more time to live, more time to do the things that we want to do, right?
Yeah, so we talk about we talk about glucose variability and how what it does to our vasculature. The vasculature, as Dr. Bono was talking about, takes an awful hit, not only in the microvascular, the kidneys, the eyes, the nerves, but also the large vessels and the coronaries.
Sure. So let's talk a little bit about the emotional side of diabetes, because sometimes we're driven by these numbers, right? The numbers are not in range. The numbers are, quote unquote, they're bad, they're good, right? And we're not talking about that. But sometimes these numbers, that drive us, that our healthcare team looks at, that's the first thing that they look at sometimes after lab work. Sometimes we feel defeated by those numbers and by this disease. So what is your advice to people that live with diabetes and cardiovascular disease? How do we continue to motivate ourselves when we're not getting the results that we'd like to see, when we're not in that range? But what advice do you give to someone who comes into your office and says, I feel really defeated by my disease?
So I can start that. What I like to say is, so we know that, and if we don't know, it's important to know that cardiovascular disease is the leading cause of death for both men and women. That being said, it's preventable 80% of the time. So that's something that I think is encouraging, and that should be a motivation for yourself, particularly if you are somebody in that higher risk group to have heart disease, and that is a diabetic. So one thing that could encourage you to do is really hone in on that lifestyle, following up with your physician, making sure that if medications are prescribed, you're taking your medications, you're checking your blood sugars, you're going in for your laboratory testing, because a lot of in particular the diseases that we as cardiologists are seeing are leading to cardiac disease are something that we can prevent and we can keep control over to really reduce your long-term risk of having a cardiac event.
That's great.
So one of the things, and I'm not sure we're going to get into COVID-19, I have a feeling that that's going to be brought up, but social isolation right now is bringing on a lot of anxiety and depression. And families are going to really need to come together and help each other. Living in close quarters brings on sometimes bad things about us. And we need to make them understand that right now is a critical time to get blood sugars under tighter control because of this pandemic that we're living through, and that I suspect is going to be around for a while.
Yeah, those are great points. I again, living with diabetes and being, sheltering in place for the last few months now, my primary goal really is to stay out of the hospital, right? To stay out of a physician's office. So for me, I really want to see that time in range, at a high percentage, at 80% of the time, 90% of the time. I'm trying to prevent lows, I'm trying to prevent highs, I'm trying to remain physically active, all while, like Dr. Lavernia said, kind of being confined, with my family, right, day in and day out, and trying to find ways to motivate myself to continue to work on diabetes, because it is progressive and it is educational. But I want to thank you both for sharing that. I think that it's really, really important that we look for our healthcare teams that provide the kind of care that you're discussing. We should all be so lucky to have a team that would include a Dr. Bond and a Dr. Lavernia to really, really take into account that diabetes affects a lot of facets of our lives. I would like to switch gears for the time now and really talk about what we just alluded to, which is COVID-19. This pandemic has really affected our country and world in ways that we could not even have imagined a few months ago. We've heard continuously that people with diabetes are at a heightened risk of experiencing challenges with COVID-19, with recovery. Why? Why is that?
Well, one of the issues that diabetes actually does, it weakens a person's immune system, and highs and lows affect white blood cells, the attack cells. So because of this, they're basically in an immune suppressed state, and that puts them at higher risk. But it gets worse if you get hospitalized and you're in an intensive care unit. Your prognosis really drops off. So as you just mentioned, you're trying to stay away from the hospital and the doctor's office. And right now, we're having a boom with telehealth, where you're telephonically connecting with your physicians, and you should really be aware that it's available to you and use it, because you do not want to meet people at the hospital or at offices, at least for right now, because once you get hospitalized, especially in type 1s like yourself, the situation gets worse. We're telling our type 1s that they should have availability at their home to either check their ketones in their urine, or there's also monitors that you can have specifically for ketones. It's not the same monitor as you use for sugar, so they're different strips. Because once you get your blood sugars above 250, we'll use that as a cut point, you should be checking your ketone level.
Sure. Does the same apply for people with type 2 diabetes?
Yes. Again, we don't see as much, but if you get somebody up with a 400 or 500 blood sugar, which a lot of people's eyes are going up, at one time we thought that they were just going to be in something we call hyperosmolar, non-ketotic, but now we're starting to see ketosis also in type 2s. But generally, when we talk about diabetic ketoacidosis, generally we're talking about type 1s.
Okay, now let's talk a little bit about these new phases of the pandemic. We hear lots of things on the news and in the media about the next wave, the second wave of COVID-19. What are some of the ways that we can continue to stay healthy as we enter these new phases of COVID?
One thing I'd like to say before we get into that, if that's okay, is that we're seeing that COVID-19, as you alluded to, anyone who has a history of cardiac disease or heart disease is at a heightened risk for severe illness. That being said, everybody is at risk to get coronavirus, COVID-19. It's just really the heart disease and the diabetic patients and the patients that have poorly controlled blood pressure or kidney disease and the elderly that are at a heightened risk for that severe illness. And myself as a cardiologist, we're seeing that this severe illness doesn't just affect the lungs, but it actually is directly affecting the heart. It's causing this surge of inflammation that goes through the body, and it causes inflammations around the lining of the heart, the muscle of the heart, and the arteries. So we're actually seeing the virus causing a heart attack. So we as cardiologists right now are really trying to figure out what's the best treatment. And again, this is a very new novel virus. It's changing every day. So we are learning in the process. One other important thing I would like to stress is that this virus is indirectly affecting our heart. And it's doing that because people are afraid to come into the hospital, right? So absolutely, if you're not having symptoms, we encourage you to avoid the hospital. But if you're presenting with any symptoms concerning for a heart attack or a stroke, May being Stroke Awareness Month, we encourage you to call 911. The hospitals are safe. We have protocols in place. We can manage both COVID as well as non-COVID patients, because it's important that we still continue to provide you with that care. As Dr. Lavernia and you, Anna, mentioned, coronavirus is not going away for really anytime soon. So we have to learn ways to sort of deal with it and manage it and really incorporate it into our normal life, because this is our new normal at this point in time. And what I do think is important, as you say, now that we're thinking about, physical distancing, and I like to call it more physical than social, because we have the ability to still communicate virtually, either with our physicians or our family and our friends through telemedicine or video conferencing of that nature. But one thing that I think is so important is that we make sure that our mental health is completely well and okay, because that does factor into your blood sugar levels and it factors into your cardiac risk as well. Another thing that I think is important is that we're making sure you're maintaining your normal preventative health. So many people right now are asking questions about a vaccination, right? Because we feel that with the coronavirus, once we have a vaccine in place, we'll hopefully be able to mitigate this. We know that that's going to take several months, but we have vaccines out there for other diseases that are placing you at just an equal risk, particularly if you're in that high risk category, like a diabetic or somebody who has cardiovascular disease. So you want to make sure that you're getting your annual flu shot. You want to make sure if you haven't received your pneumonia vaccine or your pneumovax, as we call it, that you speak to your healthcare provider about obtaining that, especially now, knowing that we have another virus out in this world that we currently don't have, unfortunately, a vaccine for, but I'm very encouraged that we will in the next few months or so. I think it's also important that we understand that we should take our medications and just make sure that if you have any questions or concerns about any of the medicines that you're on and your risk, in just overall risk of obtaining coronavirus, that you do utilize your physicians, because that's what we're here for. And I do love the fact that telemedicine is really being highlighted right now, because it's an easy way for us as clinicians to connect with you really at the comfort of your home. And several offices are using it, and I think that's going to be the new normal for us going forward.
Thank you. Thank you so much. Dr. Lavernia, do you have anything to add?
No, I think Rachel has hit all the big points. Again, reminding everybody that has diabetes that they're in an immune suppressed state, and these other vaccinations are critical. I can't tell you how many people are still not annually taking flu shots, or they're not up to date with the pneumovax, and they're at risk of pneumonias. One of the other points that has come through right now is that this virus is also attacking the beta cells, the cells that make insulin in the pancreas. So we're seeing a lot of newly onset people with high blood sugars when they get hospitalized. Not only the people that are coming in already with the diagnosis of diabetes, so we're finding out during their hospitalization that their blood sugars were elevated. Now, if a lot of them had pre-diabetes, that might be the case. One large group that we kind of left not talking about that is at high risk are patients that are obese, and they're getting hit hard. They have restriction because of their abdominal girth. The lungs suffer because of that. So that's another major group other than people with diabetes, hypertension, cardiovascular disease, kidney disease, COPD, asthma. All of these things are the high risk groups along with obesity.
Sure. Well, that's excellent advice. And thank you so much for sharing that. Thank you so much for sharing your knowledge, your expertise, your insights. We are actually running short on time, but I do hope that during the last couple of minutes, we've provided some answers to questions that you may have had. Please feel free to address any questions that we may not have addressed or answered in the comment section. We will try to reply to all of them. At this time, I would love to graciously thank Drs. Bond and Lavernia for sharing their information, for spending their time with us, Pri-Med for partnering with us on this Facebook Live, and Novo Nordisk, of course, who provided the support for this project. Please stay well, everyone. Until next time.